Well, good morning. Welcome to the UCCCN meeting. Today is June 15th. And as we probably already figured out, Mindy is away on vacation. And she asked me to be the moderator for this meeting today. And I said, yes, I would love to do it. And especially since going back many years, Dusty, that would be the meeting we always used to have, right? the medical home portal meeting. And so with that said, here is the agenda for today. First, we're going to do some welcome and introductions. And then Athena will give us some medical home portal updates. And then we are going to spend some time on brainstorming, identifying resources, or if you do a quality improvement project in your clinic, please let us know. And then around 9 o'clock, a little bit after 9 o'clock, we're going to hand it over to Eric and Dusty. And they're going to present the power of care coordination in a medical home model. And we will wrap up at 9:55, and the meeting will promptly end at 10 o'clock. Okay, so let's start with the introduction. I will start out, and then I will read out the names as they are listed on my computer over here. So my name is Gabi Baragoshi. I'm a quality improvement specialist at UPIC. Have been here for now seven and a half years, and have worked with several people who are on the call today already in the past. And with that, I'm going to hand it over to Michelle.
Thanks, Gabby. Good morning. I'm Michelle Redfield. I'm the administrative assistant for the Medical Home Portal and UCCCN.
Good. Athena.
Hi, Athena Parker with the Medical Home Portal, and I work with all of our state partners.
Perfect. Dusty.
Yeah, I'm Dusty Frisby-Housel, and I am the medical home administrator for Wasatch Pediatrics.
Good. Eric.
Good morning, Eric Christensen. I'm the program manager with the Integrated Services Program with the Utah Department of Health and Human Services.
Great, thanks, Eric. Heather.
Good morning. I'm Heather Carlson. I'm part of Eric's group. I'm a nurse care coordinator for the Integrated Services Program.
Okay, thanks so much, Heather. Julie Southwick.
Hi, this is Julie. I am the transition specialist with Eric's group.
Oh, nice. All right. And then we have Natalie Allen. Please go ahead, introduce yourself.
Hi, sorry, I don't have my camera on because I'm driving. I'm Natalie Allen. I'm the nurse practitioner with Integrated Services Program, Eric's team.
Great, wonderful. Thank you. Shelley? Shelley, I don't know if you can hear me, but you might have to unmute yourself to talk. But we will move on to Sylvia. Hey, Sylvia, long time no seen. Please introduce yourself.
Hi, I'm Sylvia Barragon, and I'm the nurse care manager for the University Developmental Assessment Clinics.
Oh, nice, thanks. Tina.
Hi, I'm Tina Purcells. I am with Utah Family Voices at the Utah Parent Center, and I'm also an author for the Medical Home Portal.
Nice, thanks, Tina. Walt.
Good morning. I'm Walt with Integrated Services Program with the Department of Health, also with Eric's group, and I'm a care coordinator in the Salt Lake area.
Oh, wonderful. And then we have Whitney. Whitney, please unmute yourself, and if you could introduce yourself, that would be awesome. If not, you can type it into the chat box and I can read it out loud. All right, Whitney, we will give you some time. I will go over to who's logged in.
Rebecca?
Rebecca, yes. Rebecca, would you like to introduce yourself?
Sure. My name is Rebecca Cellino, and I work at the University of Utah as a care manager in Farmington.
Farmington, great. Are you working mainly with pediatric patients up there?
No, I work at the family practice, so we have both. So we have pediatricians and
okay. And there's only one care manager up in Farmington for the whole building?
Correct.
Wow, you have your work cut out. Yeah.
Well, I do have what we call care manager assistants. So I have 2 of those too, and they're great. They're awesome. So
without them, you would be drowning probably.
Yes, exactly. Yep.
Good. Thanks so much.
Yep. Thank you.
So I think we have pretty much caught everybody out. So if people join later, then we always can stop and ask them to introduce themselves, but let's move on. Okay, a couple of housekeeping items. So the best experiences on Zoom is via computer. So, you know, on your iPhone or on your smartphone is maybe not as good, but on a computer. And as mentioned before, we will end promptly at 10 a.m. Okay, so here is going to be my little selling point on the Spark for Autism study. So since I am one of the study coordinators on that study, so the University of Utah Healthcare is one of the recruitment sites for the Spark for Autism study, which is one of the largest study in the nation, I would even say in the world, maybe. The aim is to enroll 50,000 families with children who have autism. And we would like you to bring this information back to your practice. And if you encounter a family with autism, who have a child with autism, then to ask them if they would like to join the study. You can reach out to us, or you can refer them to the link to sign up, which is very easy. Just let us know. I can stop by your clinic and drop off some brochures, give you a little introduction, more introduction on the Spark study, and just want to let you know that we are here for you guys to help to support those families. The pediatric project echoes. So the spring season has come to a close. So they are over the summertime. There's no project echo going on. It will restart in, I believe, August 17th or so, right, Michelle? Yeah. So August 17th. And if you can go to this link, which is right below here, to see other recordings of the Peds Echo webinars. And then the pediatric project echo, which is the Autism 101 echo schedule. So it's still going on until probably September. And the next session is next week, I believe, yeah, 22nd. And Dr. Bolkabon is going to talk about medical co-occurrences conditions in children with autism. I have heard this talk before, and I only can highly recommend to listen to it. It covers quite a variety of co-occurrent conditions. It could be constipation, weight gain, sleep hygiene. So it is really quite informative. And now I will hand it over to actually Athena to give us a medical home portal update. I believe one of the new features is showing service provider search results. And I will go to the next slide over here. Athena, please take it away.
Great. Can I actually share my screen, Gabby?
Yes, absolutely. Stop sharing.
Great. I'll just show this feature in the live version. That way it's a little easier to show. But within the service directory, now we've added a new map feature. And so if you're searching a category, for example, or a term, I'm just going to choose this disability rights group as an example. You'll see that now we have this little legend that shows when something's a local service, a statewide service, and a nationwide service. And we just kind of wanted to make those distinguishes on the map so that people can find services that they might be able to access, even though that little pinpoint on the map isn't in their area. So these yellow dots are going to be services that are usually web-based or resource services online. They could be a hotline that people could call, those kinds of services that people can access no matter where they live. And the blue dots are going to be either a local or regional, or sorry, statewide or regional service. Same thing, it may mean that they could access services through a satellite office, a hotline, web services, telehealth, that kind of thing. And then the red dots are going to be those ones where they would need to probably, or want to live close to that location or be able to go to that location to receive the service. So that's one of our new features on the portal. And again, if you ever see map pin waypoints that are not correct, you can always click on the waypoint right here, and there's this little feedback button that you can let us know if there's something is wrong about that waypoint. So we appreciate any feedback we can get on that.
Oh, it looks good. Nice. All right, I will share my screen again. Okay. Yeah. Okay, any questions for Athena before we move on to the brainstorming session? No? Oh, we have a couple of new guests. So Natalie Carter. Natalie, would you like to introduce yourself so we can know who you are?
Sure. Can you hear me?
Yep.
Okay, so I'm Natalie Carter. I am the Children's with Special Healthcare Needs Coordinator here in Central Utah, and I'm a part of Eric Christensen's team.
Oh, perfect. Thanks so much. And then Antonia Estrada, I think we have not heard from you today. So could you please tell us more about you? Okay, integrated services. She wrote in the chat box. Thanks, Antonia. Tony Estrada with integrated services. Welcome. And then Angie Richards. I believe you have, I believe you have no audio hooked up to this call. So maybe you can type in the chat box so I can read it out loud. I will give it up to you. All right, moving on. Brainstorming. So this is the time really where we would like to hand it over to you guys to talk about cases you are struggling with, and you could use some input from other care coordinators, or you want to mention a very, good situation that you were able to solve and how you solved it. It would be good for other people to learn how you did it. If you know anything about your resources, or you are doing some QI projects in your clinic and you want to talk about it, this is now your time, and I will shut up and try to listen to you guys.
I just wanted to ask a question generally of the group. When referring out for patients who are needing autism evaluation and diagnosis, what generally is your wait time for generally for folks getting in for a visit? And I meet weekly with our friends at UDAC, and I haven't asked them in a while, kind of, how, what sort of a backlog they have, because I know they do such great work and they're incredibly popular. But Sylvia, let me ask you first, kind of what's kind of your turnaround time for someone who, like, a new intake or something, and it's going to be, how long are you telling folks it's going to be before you probably can get them in for like a full evaluation with you guys?
That is a great question, Eric, and I'm curious to hear what people have to say.
So it depends on the child's age as well, if they're 5 and under versus 5 and over, and who they're going to see on our team. But it is taking, after they've been seen for the initial welcome visit, which can take up to 6 months to get into. After that, it could be anywhere from, I want to say, 2 to 4 months, depending on the child's age.
Okay, so 6 months for the welcome, and then it could be 2 to 4 after the welcome, depending on where you kind of have to slice and dice and place the kiddo with your team.
Yes, yes.
Okay.
And Sylvia, that's such a great timing that you're on a call today with the question Eric posted, because you would be the person with that information working at UDAC. Yes.
And sometimes there are cancellations and we're able to get people in sooner, but for the most part, that is the wait.
Right. And are you still doing the majority of your visits via telehealth for this sort of thing, or hybrid? Okay.
Yes, both telehealth and in person. And if they're out of state, it's in person at this time.
Okay. And is there a longer wait depending on whether it's in person versus telehealth? Does that make a difference?
We are seeing more in person. Yes, there may be a longer wait just because this we have more people who are, if they're out of state, that we're needing to get in person. But the last time I spoke to scheduling, it looked like it was half and half, but it's changing. It's constantly changing. We are seeing more people in clinic, as restrictions are lifting and whatnot. So we have been seeing more in person. Yesterday, we had a full CDP clinic in person.
Okay, fantastic. Good to know. And then just generically for other folks out there that might be referring out to other places, what are you finding your time frame is? Or are we still looking? I know that maybe a month or two ago, kind of the average was like 8 to 9 months kind of to get in generically. Is that still generally the consensus that our care coordinators are finding out there to get folks in for ASD?
Eric, so in general, yes, but I don't know if I want to reveal this or not, because I found somebody who has immediate availability. So I am totally shooting myself in the foot for getting my patients in. But Dr. Julia Hood is doing ADOS evaluations. And anyway, through the summer, as she's not teaching, so she's right now a professor at the University of Utah. And I know she has immediate availability. I've referred a couple of people into her, and I mean, they have gotten in within 2 weeks, 3 weeks.
Dusty, is she able to take insurance, or is she just a private pay?
I didn't even ask.
Okay.
I did not even ask. I told parents, you will have to call and find out. It may be an option for you. You will have to decide. I heard she had availability and I just started immediately referring. So I can find out. I have it. I do have that information on an internal database that we have. I just have to look it up.
Okay, that's good to know. All right.
That's good. So Sylvia, let me ask you, because now, I want to use you since you're here in for UDAC. Is UDAC actually working on getting the waiting time down for the autism screening?
We are trying super hard, but just to give a little insight as to how many referrals, yesterday when I was speaking to our front desk, we have 2,000 referrals in our wait queue. So,
goodness.
Yeah.
Holy smoly. Yeah.
But we're trying, but there is a huge amount of referrals that are waiting to get in. So.
Mm-hmm. Yeah. Wow. All right. Thanks, Eric, for opening up the can of worms regarding wait time. Now everybody's kind of discouraged, but
no, it just proves the point that there is a huge need, and we don't have enough providers who can, who really can do this. Mm-hmm. So that it proves that point.
Okay. Yeah. All right, then we still have a few minutes left in our brainstorming session. So I would like to open it up again to the group. If there's any difficult cases out there, you could use some feedback from the people here on the call. Please speak up. Just see it, Yvette joined us. Hi, Yvette. She is the care coordinator from UPC.
I'm going to just interject one more thing, and not necessarily a case, but I always like to put a plug in for our Chromebooks and hotspots that we have around the state. We don't use them to capacity, and we really want to make folks aware of that for anyone who might have telehealth, teleconsultation needs. We have Chromebooks placed at the Utah Parent Center. We have placed them also in San Juan at the local health department. Central Utah, we have some in Richfield. There are Chromebooks also and hotspots, so also in Price and Moab. And then we place some in Vernal as well. And then Tony Estrada has some in Ogden as well. And we are happy to loan those out for an extended period. Initially, when we got those last year, we thought we might have to really restrict and say, well, family might need to use it and get it back as quickly as possible, but we have not had those utilized to the extent that we thought we might. So we are able to loan those out for an extended period until such point we find that we have greater demand. So if you know of families who could, benefit, maybe a family who has ongoing therapy, a family who might be receiving early intervention services remotely and might need a unit that, this could help facilitate those types of visits, we can loan those out for an extended period. So if you do have questions on that, you can reach out to the integrated services team generically, and we can put you in contact with whomever would be the closest care coordinator with access to those devices, and have an agreement signed with the family so that those can be loaned out.
Great information. Thanks, Eric. That sounds really good.
I have a one, Gabby, as well, that I was just thinking of a request somebody had submitted into the medical home portal to be added to the directory. It's a new ABA service called ABA Services of Utah, and they're located in Spanish Fork. And I'll put the link in the chat and then also include it in our resources of the month notes that'll go out.
Good. Right. Thanks so much. Well, since I'm a quality improvement coach or specialist, so I would like to talk a little bit about quality improvement and just tell you what actually I accomplished this week, which might sound little to you guys, but it was a huge win for me. So we are working on so our project is a behavioral health integration QI project, and we are working up in Logan with primary care pediatrics. And one of the biggest, not complaints, but biggest issue was, getting the Medicaid children into Bear River Mental Health. So it's the only organization who serves Medicaid children up there, to get them into a therapy in a timely manner. So now we finally were able actually to connect primary care pediatrics and Bear River Mental Health, and was this week. And finally they got to know each other, see each other, talk to each other, exchange contact information. And also we are going to try out a new referral form where the practice is faxed into Bear River Mental Health with the release of information already on it. And Bear River Mental Health will reach out to the family, versus before it was up to the family to reach out to Bear River Mental Health. And they will report back to the practice if they were able to get hold of the patient. So we're going to try it out with the next few months to see how it works. But I thought it was great. I was very excited. I'm very excited about this. So that is my quality improvement win.
Excuse me, Gabby, may I clarify something quickly?
Uh-huh.
So for the younger children, it's a 6-month wait list, about a 6-month wait list. For our older kiddos, it's 6 to 8 months. And this is assuming the parents have turned in all of their questionnaires and have turned in what we've sent out to them. So just to clarify on the wait time.
Clarify the waiting time at UDAC. Thanks so much, Sylvia, for updating us. Yeah. Okay. This is the last chance for anybody to speak up on about anything you want to speak up on. So before I hand it over to Dusty and Eric.
Sylvia, can I ask a clarifying question on that you just said? So 6 months for intake for younger kids and then 6 to 8 months for older kids. Is that what you're saying, or total time that they're waiting?
You're muted.
Sorry, for the initial welcome visit or intake visit.
6 months for younger, 6 to 8 months for older.
Yes.
Okay.
Thanks, Atina, for asking the question. Thanks, Sylvia, for clarifying it. Okay, with that, I will actually stop sharing my screen. Eric and Dusty, you are going to share your slides, yeah?
Actually, Michelle is going to share those
okay,
for
so
us. Yeah, we sent those ahead of time. And I'm just going to start yapping here and do some introductions. I introduced myself earlier, but my name is Eric Christensen. I am the program manager with Utah Department of Health Integrated Services Program. I've been with the Department of Health 23 years and been fortunate enough to work in that time frame with children with special healthcare needs, and have had a great experience working with families around the state. I'm bilingual English-Spanish and have a real passion for working with our Spanish-speaking community, working with underserved families around the state, and have thoroughly enjoyed my time frame doing that. In those 23 years, I have made some incredible connections with professionals from other organizations around the state, worked very closely with the amazing team from UPIC, from Utah Children's Care Coordination Network, our friends at General Pediatrics, a lot of you on this call. And during that time frame, worked very closely with Dusty, who's on this call with me today. And I'm delighted that she was willing to tag team with me on this. Dusty is the consummate professional when it comes to care coordination, with just having it all together when it comes to providing care coordination in a medical home. And so the fact that she was willing to tag team on this today, I'm just very grateful to her. I'm going to give her just a minute to introduce herself, a little bit of her background and where she comes from and what they're doing, kind of in their practice. She's changed roles ever so slightly. When we first started care coordination with Integrated Services Program, she was very gracious and had us come up to Summit Pediatrics and meet with, we met with her and their parent partner. It feels like a million years ago, but it was probably, I want to say maybe 2015-ish that we came up and met with them, and they were gracious and showed us the ropes and gave us some really, really terrific pointers that we still use to this day. So with that said, I'm going to turn just a few minutes over to Dusty, and then we'll hop into our presentation.
Thank you, Eric. That was very kind. So I have been with Wasatch Pediatrics for 15 years, and I've been in a role of a care coordinator almost as long. So probably, I don't know, 10 to 12 years. I forget which year I exactly started doing this. We have, care coordination in our clinic, and I think in just clinics in general, it's kind of an ebb and flow. And so when we're working in general pediatrics, sometimes we do a great job at it. And sometimes we have other things where we get pulled into clinical work, and those times maybe we don't do quite so well. We strive to certainly be a medical home, although I will say we're not a certified medical home, right? But we do consider ourselves a medical home. We have 8 clinics up and down the Wasatch Front, for those of you who are not familiar with Wasatch Pediatrics, and most of them have a care coordinator available in those clinics. So I'm really excited for this topic and kind of talking about care coordination in the within the confines of a medical home. And the thing that Eric and I specifically kind of talked about was, as you'll see as we kind of get into this, is coordinating the coordinators, right? And how do we best help each other? So thanks, Eric.
You bet. Well, again, excited to be here. Michelle, can we have the next slide? So we are going to try something out today, and we're going to hope it works with Michelle running the Wurlitzer. I was going to try to have backup on my computer this morning, my state computer, in case we can't get the Poll Everywhere to work here. So we're going to ask a few survey questions this morning. We'd like to see if we can make that work. So if you are on a web browser, you can go to the pollev.com, Eric Christian 389, or if you're on your cell phone and you'd like to just do it separately from your web browser, you can text Eric Christian 389 to 22333. Boy, that sounds like an infomercial, doesn't it? But you can hopefully log on that way and take these polls. Now, if we find it doesn't work, we may just ask you all to do the raise your hand feature on the on any of the poll questions that we ask. So this is a bit of an experiment today, and it may be a failed experiment by the time we're done. One other thing I want to point out, I apologize for the messy background. I am in the middle of a move. I will be moving next Monday on Juneteenth, and my house looks like a total train wreck. So I don't want you to think I live in squalor. It is just for the next few days. So anyway, please disregard the mess in the background. With that said, if everyone's had enough time to try to get this logged in, Michelle, if you give us the next slide. This is our first poll question. So let's see if we can make this work. And right now there's some at the bottom that says start the presentation, see live content. Let's hope this is going to work for us. So we want to see what everyone's medical homeness status is. Do you use the term medical home for your practice? Do you not use the term? Do you not consider your practice to be medical home? Or are you one of the people on the call that maybe you're not from a pediatric practice or from a family practice? And if that is the case, and I'm not seeing anything coming up on here, so I'm thinking maybe the poll is not working. Michelle, are you seeing anything on your end from there? And
I'm not. Is there something I need to log into to get it to work?
You know what? I don't know. I had to download that to my actual computer. Let's do something here really quickly.
Eric, I'm on. Eric. I got on and it's coming up from our transition presentation yesterday. Those questions.
Yeah, me too. It's got transition questions.
Yeah, that's what I was noticing as well. It's different questions.
Is it pulling up different questions? So it's not pulling.
Yeah, it's from our presentation yesterday.
All right. So you know what, folks, what I'm going to say is let's leave this alone. It's wonky. So let's just ask these questions here. Let me ask folks to just kind of, you know, pipe in and ask this, but how many of you folks consider yourselves to be a medical home? How many of you use the term for the practice that you represent, the term medical home? Do we have the ability for folks to raise hands on here that I can just kind of see that raise hand feature? If you use the term medical home to describe your practice, like within your practices, okay, so let's see, I'm going to pull up the chat. Alpine Peds is certified medical home. Thanks, Angie.
This is Tina. I don't know if our doctor calls his practice a medical home, but boy, does he provide a medical home.
Okay, perfect. All right. Now I threw one question on there where we said, I'm not sure what medical home is. So the term is an interesting concept there. So that's what we kind of wondered. All right, let's go to that next slide. All right, let's give you a little quick quiz. The term medical home, if you just talk to any people on the street, what's a medical home? But let's ask you folks who might have heard the term a little bit more. What year did that come into our vernacular, that medical vocabulary, the term medical home? How long has that term been around? What do we think?
Can I say it? Can I scream it out?
Scream it out.
1992.
Tina, you are a valedictorian on this call. That is the correct answer. Now, I put 1967 because that's the year I was born. And for some reason in my head, until I researched it, I thought that thing had been around, that term had been around for like 50 plus years. Yes, I will be 55 in October. I know I am an image of youth, but yes, I thought that had been around for forever. Actually, 1992 was when the American Academy of Pediatrics kind of came up with that term. Let's go ahead and have the next slide. All right, so let's ask this, and I'm just going to throw this out for general discussion. And we would have asked folks to throw this, populate in some words here. What is a medical home? What does that mean? Do any folks want to shout out, throw some terms out there? What's meant by medical home?
Put the patient in the center of the care.
Okay. Anybody else?
I know.
Please.
Medical home is not a
It's not.
clinic or a place. It is an idea. And it is an idea to provide quality care for anyone, really. But it's more of an idea, and it provides culturally competent. I don't remember all the things, but yeah.
And you don't have to, because we have a slide on that one, but I appreciate that. Okay, so it's an idea, but I am going to argue with you and say it can be a place. Because if you employ this, it can be a place. So Angie said in the chat, it's comprehensive, it's team-based care. Natalie Allen said it's patient-centered. Okay, I'll agree with all of that. Let's go ahead and look at the next slide. Okay, so what we want to know is, why did you choose the answer that you did on that very first poll question? So like if you would have said, we don't consider ourselves to be a medical home, or we don't use the term medical home, or we do use the term medical home, why did you choose that answer up front? Why would you not use the term medical home to describe your practice? If any of you would have chosen that answer, why would you have chosen that answer? Why would you say, well, we really don't consider ourselves to be a medical home?
I'll raise my hand. I didn't choose that answer because it provides what I believe is, or what I thought is, all of the patient's care, including preventive medicine, physical. So it encompasses all of the patient's needs, where our clinic is, although we see patients on a regular basis, we're not their primary care provider.
Okay, and that's perfect, Sylvia, because not every practice is or probably should be a medical home. That makes perfect sense. What about anybody else who is primary care? Gabby, do you want to chat that up?
So I think over the last few years, everybody has become so focused of becoming NCQA, patient-centered medical home certified, that people, when they hear medical home, that they automatically think, oh, I got to be certified in order to call myself or call my clinic medical home. And so they maybe choose to say no, versus, there's a lot of practices out there who are not certified, but still function as a medical home for their patient.
Okay, I like that answer. Does anybody else have? Okay, so let's see what Angie says. Becoming a certified medical home is an extensive process where the practice shows that they meet very specific requirements. Angie, was your practice a medical home before you became involved with that practice?
No.
Okay. Well, so was that a massive process to go through?
It was, and our population health coordinator, Caitlin Smith, was integral to that. I certainly don't exist in a vacuum, and her efforts were enormous in creating care management process, and then born out of that was our behavioral health program that we are also certified in. So it's no joke. You got a lot of hoops to jump through.
Right. And I'm sure it's been very lucrative for you, right? Because it sure yields huge returns when you're a certified medical home, right?
Well, it definitely can affect, your rating with insurance companies and how you bill. So yes, that it is impactful.
Okay, I appreciate that answer. I was being sarcastic because generally a lot of times places are saying you don't really necessarily yield huge returns, but quite often the perception is what's of value. And Gabby, I think I've cut you off now twice. Please go ahead and say what you were going to say.
No, not a problem. No, I agree with Angie. You know, becoming certified medical home is quite a process, and I'm sure Yvette from UPC can attest to that one. But I also would argue that, you know, so UPC is now a NCQA certified patient-centered medical home, but I would argue that before the process, they already were a medical home clinic because they really put the patient in the center and had care coordination, and so they just were not certified, but still a medical home.
Oh, I think very much so. I think there's a lot of practices out there, as evidenced by this conversation, that really do provide that care. It's just like next level to go through their certification process, and it can change like your practices standing with, you know, how they're recommended to patients as being, you know, a primary care provider option and things. So, you know, it can be helpful to a practice.
Can be, but it's also very costly to practices. It's
and consequently would probably not be really a feasible option for some practices.
Yeah. And you know, Utah, out here in Utah, so if you go to the East Coast, being NCQA PCMH certified probably has a more financial reward than being out here in Utah, where there is less so much a financial reward.
Well, I appreciate that discussion on that. Very interesting stuff. And, you know, Angie, Gabby, thank you for those comments. Let's go to our next slide. All right, so Tina, here we go. This is what you were referring to a few minutes ago. These are, Dusty, this is, you know, kind of what we talked about the other day. We talked about seven components. I didn't know if this is one you want to kind of address as, you know, from your perspective with having, you know, that medical home piece with Wasatch Pediatrics.
Yeah, so I think that a lot of pediatric offices are certainly familiar with medical home. And over the past few years, certainly medical home has become kind of this key word, right, that we all tend to use. As we're looking at those that have care coordination available, and those that can really consider themselves medical home, I think most have looked at the NCQA requirements and really strive, whether they're certified or not, to be accessible, to have continuity of care, to provide comprehensive care and help facilitate referrals, warm handoffs, stuff like that, to keep our family at the center. You know, we were very fortunate to have a parent partner in our clinic who really drove this fact home. I had a conversation with Tina last week about a family that I'm really, really concerned about. And the child has their, you know, all of these issues. Mom has no respite. And so mom is on survival mode. And so for her to be able to follow through with recommendations at this point, I mean, that's almost non-existent, right? And so we have to meet the families where they are and get them resources where they need them, as they need them, before we can address some other things. And so I think that I've been very fortunate to be really steeped in this idea of family-centered from the perspective of a parent. And I don't think I can ever view my patients any other way again, right? So non-compliance, which is, you know, everyone's favorite word in the most sarcastic of senses. I really don't view families as being non-compliant. I look at where do we need to meet them. coordinating care is, again, just so important. And that does not necessarily mean that every clinic needs a coordinator. Not all of them need a coordinator, but how do we communicate with families? How do we check for understanding? How do we follow through with referrals or help the families follow through with referrals? And then we want to be compassionate. And I think that really drives back to being family-centered and culturally effective. We had a huge discussion in our office yesterday around behavioral health and how can we be culturally effective in talking to families and make sure that we're not making assumptions about a patient's or a family's perception about behavioral health or diagnosis or things along those lines. But how do we present information in a respectful way and respect somebody's culture, regardless of what that is? So you got a long-winded answer, Eric.
No, and that was perfect because it talks about the practical application of all of those just in a few sentences. So I think that's just very, very helpful to discuss, how that how that works and how that comes into play on a daily basis. All right, let's go to our next slide. And let me just show you really quickly. I want to explain this from kind of a contextual standpoint. So every year, Utah receives maternal child health block grant monies. And part of that process for receiving those monies is to submit an annual report and then an annual plan to the Health Resources and Services Administration, so HRSA, and the Maternal Child Health Bureau under HRSA. So we submit block grant request and report, and we report on a couple of goals, one of which is number of families who report that they have received care within a medical home. And the other one is families who report that they are receiving the services necessary for their youth to transition to adult health care. So those are National Performance Measures 11 and 12. Now, there is a pre-screening questionnaire that goes to families on the National Survey of Children's Health, and that survey goes out every year. And that has started back in 2016 that they started doing that annually. Prior to that, it was haphazard. Every 5 or 6 years they did that survey. But in 2016, they started doing that annually. Each state, they hit up anywhere between 750 to 1,000 different families to get a pulse on what's going on with kids in the state on this National Survey of Children's Health. There's a screening questionnaire. And they look at that screening questionnaire to determine if there are children with special health care needs in the household. And they look to see, do you have kids who have chronic health conditions, who have behavioral health needs, who have social emotional type needs, and or who use healthcare at a rate greater than that of the general pediatric population. And depending on how families answer those questions, determine whether that household has children with special healthcare needs. So based off of that, families then answer questions and fall either into the general pediatric pool or the children with special healthcare needs pool. So, based off of this, on the 2018 and 19 combined data set and the 2019 and 2020 combined data set, I have those numbers off to the right there. So for children with special healthcare needs, 2018, 2019, 46.4% of the families surveyed indicated that they were receiving services within a medical home model. Looking at the 2019-2020 data set, that went up to 57.2%. Now realize this is a random survey. So this is not a static set of families that they call year after year after year. It's not a cohort of families. This is random calling. So we improved greatly by almost 11%, just a little under 11%, from one year to the next. Now they do a combined data set because when you look at only 750 families, contacted in the state, you have a very small number to look at. And it's determined that right around 15.8% of children in the state of Utah qualify as having a special healthcare need. Now, nationally, that was for that same time period was right around 19%. I fail to believe that we have fewer kids in Utah with special healthcare needs than the rest of the nation. But for some reason, our numbers came out to be right around, like I said, 15.8% of kids with special healthcare needs. So when you look at a small number, 15.8% of 750 families surveyed, that's why we do a combined data set. Now, when you look at children, non-CSHCN families, those numbers remain relatively steady and right around that 2019-2020 CSHCN number, 56.5 for the 2018-2019 and 55.4 for the 2019-20 data sets respectively. So, slightly more than half of families surveyed indicated that they are receiving services within that medical home. Now let's go to the next slide, because that's going to indicate what those questions were within the survey that families said they received it within the medical home model. So families had access to a personal doctor or nurse. So this means families aren't getting their usual and customary care through the ER. They're not getting all their shots through the WIC clinic. They have a personal doctor or nurse, be that a pediatrician or a family practice, whatever. They have a usual source of sick care. Once again, kid has a fever, kid has a cough, kid's sniffling, sneezing, achy, stuffy head fever. They're not going to the ER for that. They have a usual source of sick care. They have family-centered care. They feel that there's a family focus and they feel good about the care that they're receiving. No problems getting needed referrals. Now I added the no, because problems getting needed referrals is not the measure, it's no problems getting needed referrals. So if the family has need for a referral, be that to a medical specialist, behavioral health, social services, whatever type, educational type of referral, family gets the referral as needed. And then number 5, and super important here, is that they have effective care coordination when needed. So those were the factors that they looked at on the survey, and it's an amalgam of several questions that go through the survey. So here's another question. So if we'll go to the next slide, based off of the 2002 American Academy of Pediatrics policy statement, how many desirable characteristics are there in a medical home? So I want you to reflect back and think about this a little bit. We have 7, 10, 18, or 35. How many desirable characteristics would there be within the medical home? And just so you know, even though the original policy statement came out in 1992, in 2002, they were ratified again by American Academy of Pediatrics. What do we think the answer is? Tina says 10. What does everybody else think? You can shout out if you want. 7, 10, 18, or 35. Okay, so Natalie says 7, like we originally saw. Okay. Let me tell you what the answer is. Guess what? The answer is 35. So they didn't just leave those 7 there. They parsed it out even more under those other categories. Now, I just want you to know these next slides are super busy, and I violated the first, code of all things that are PowerPoint presentations by slamming too much onto a slide. I do not expect you to squint at these slides. This one is decent. There, I have a couple of them that you're going to say, wow, those are 4-point font. You can look at them on your own time. We're not going to go through everything, but I want you to look and see as these slides come up and we go through them a little bit, to kind of look and see what types of things actually fall under care coordination. So under accessible care, they broke down 6 parts and pieces. And there are important things on here. It's accessible. Care is provided in the community. You can get there on public transportation if you need to. Families can speak directly with the physician as needed. It meets ADA requirements. Changes in insurance are accommodated. All insurance is accepted, including Medicaid. So this isn't concierge care. Okay, so it's accessible. Let's look at the next slide. It's family-centered. Okay, guys, this is where it gets a little wonky and crowded. But let's think about some of these that may be care coordination related. The family knows the physician. There's trust in that practice between the physician and I'm going to say between staff. You know, we trusted our physician when my kids were growing up. My oldest is 30, my youngest is 24. We trusted our physician and we loved the staff in our primary care office. And all 3 of my kids went through that office at Wasatch Pediatrics, and we thought they were fantastic. The family is recognized as a principal caregiver and center of strength and support for the child. Complete information shared with the family. Families and youth are supported to play a central role in care coordination. That's an important one right there. Let's ask this to all of you, and just kind of almost a rhetorical question. How many of you really focus your care coordination on not just what the doctor said needed to happen, or your provider in the office, your nurse practitioner, your PA, but really focus on those needs of the family? Quite often, I can speak for integrated services, we get a referral and we'll hear, the family needs, please connect family with X. But when we dig into the weeds and we talk to that family, we realize family just doesn't need X. They need, you know, A through W as well. And we work with the family to figure that out. Families share in decision-making, and the families recognize as the expert in their child care. I don't know, I saw 3 or 4 things in there that really relate to effective care coordination. Dusty, you able to take that next one?
Yeah, can we see the next slide then? Oh, there it went. Sorry, I'm just behind.
No, we do need to do the next, actually.
Oh, there we go. Yep.
There we go.
There we go. I was like, wait a minute. So, to this continuous, it is continuity of care, right? So the same pediatric professionals are available from infancy through adolescence, right? Or even up until to young adulthood. So most pediatrics go to 20 or 21. And family practice, of course, is, you know, cradle to grave. So assistance with transitions. So this is the transitions. I really have to say, I think there are so many transitions in with kids, and especially our kids with and families with children with special healthcare needs. This is where having somebody who knows, right? So Tina and her group, who knows these transitions, who can also help families through these transitions. Having the physician talk through, you know, care and stuff like that is really valuable, that anticipatory guidance, and then having a family who's been there is super valuable. And I think what I was certainly driving at was 16, which is The physician participates in the fullest extent of allowed care and discharge planning as the child is hospitalized or care is provided by another provider or facility. Oftentimes those are our transitional times, certainly with our families.
Dusty Land, let me ask you this. I mean, and this is sometimes where I think care coordination and coordinating care coordinators gets a little bit wonky, is, you know, that referring out, and then maybe we have additional care coordination coming in. How do you feel, and let's throw this maybe out to the group as well, when you've made a referral out, or there's discharge planning, or, you know, someone else is stepping into that role, how do you coordinate care coordination amongst those, you know, multiple care coordinators?
Yeah, so this is kind of the age-old question, right? That really kind of prompted this this presentation and this discussion is, you know, how do we coordinate care coordinators and who takes the lead when? One of the examples I had shared with Eric was, you know, and again, I'm happy to have information go to families when they need it. And so certainly I don't have to be the keeper of all things for my families. But I had a patient that I had been working with. We had concerns for autism. And as we were getting this kiddo into services with early intervention and waiting for them to get their evaluation with UDAC, we were certainly doing some care coordination, follow-up, you know, chatting with early intervention to see a progress and stuff like that, as well as making sure we weren't missing something else. As the UDAC evaluation was done, this child was referred into integrative services for care coordination. And I heard, which is great. Again, I was really grateful for the information they provided, and it really reinforced the information I had given the family. But then when they came back to me, they said, oh yeah, I've got to follow up they had somebody I'm supposed to follow up with. And I said, oh yeah, I know that team. I said, they're great. Tell me what their recommendations were, and you know, and you can choose to go with them, or I can help you with this. And so that's where I think it gets wonky, like Eric was talking about, where are those handoff points, and where is it just too much for families and maybe overwhelming, and where is it maybe families need to hear about this in several different places and they may need additional support to help follow through. So as a group, I would be interested to hear your feedback about cases you've had, or even on that specific example.
Let's throw that out to the group. What does everybody think? What's your opinion? What is the best way to ensure that families are getting what they need, not too much, not too overwhelming, and to ensure that families, or best way to find out if families are getting other care coordination from another source? Do you have any tips, tricks? Do any of you in your practices have ways that you do that? Let's just ask this, do you ask that question? Do you have other care coordinators? Do you have anybody else that's working with you on this?
So initially, when I work with our families here at UBC, at their visits, I will come in and sit down and gather just a gist of where they are, who they are seeing, who we need to connect with. So I make a list. And I let family know, this is who I'm going to be calling. This is off of your shoulders. Let me know if you hear anything. I'll communicate, so we're not having the patient or the family be the middleman going back and forth. So I will usually get those phone numbers, contact the individual who either we're referring to or who we're connecting care with, or doing warm handoffs rather than just sending on over a referral and making sure that the families are receiving what they are needing. Now going back to wanting to know whether they received those services, rather than following up with the family, I follow up with the person or the individuals who we're referring to ensure that we hit X, Y, and Z. And if anything else is needing to be done on my end, I will make sure that I follow back and see how else can we further help this family to ensure we're doing a close circle and not leaving anything out of that loop.
Well, that is a textbook awesome answer, Yvette. Thank you very much. I appreciate that. You know, I'm going to tell you what, and I'm just going to generically speak, and I can't speak for my team because honestly, I don't do care coordination anymore. I get the super fun grant writing and reporting and, you know, not super patient connected things anymore that I totally miss. My team does an absolutely bang up job helping families and working with families and some of the rest of it. But I don't know if always my team finds out when we get a referral. I think they jump in with both feet, but I don't know if they always find out if there's another primary care provider, care coordinator involved. And that's no fault of my team. You know, my team's only as strong as the leadership provided to them, and it's not something I think I've thought to coach them on. And Dusty and I had a really interesting conversation. So one of the pieces we always joke is, it's like herding cats sometimes, coordinating these bunch of these awesome do-gooder care coordinators who all are trying to do their best for the family. But how do we make sure that we're not undermining the work being done by other people? And until such point that we have some sort of a closed loop referral system that we can all tap into and see what's being done in other places, sometimes the best thing to do is to just flat out ask the family, hey, where are you receiving services? And is anyone helping you get those services at those points of contact? So really, really good piece. And thank you,
Eric,
Nat, please.
I just want to say, like, I love this conversation because I think Eric's absolutely right. I don't always ask the families. However, I'm going to say that even if you ask families, they probably don't know that answer because they get confused. So even if you say, did you already, they don't understand that. This information generally comes out when you're interviewing the family and talking about who they're working with, and they're kind of confused. They don't know, and they'll say, well, I was supposed to talk to such and such, but they don't necessarily understand that they were already getting services from someone else. So I think that is a responsibility as us as providers and me when I see families to do a better job at coordinating with the primary care provider. I mean, if I can identify that there was a primary care provider, I am now committing to doing a better job of following up with the primary care provider and finding out what they want help with. But I don't think families know the answer, Eric. Even if you ask them, I don't think they understand all the systems well enough. Maybe some of them, but that's just my 2 cents.
Okay, and I appreciate that perspective as well. But if we don't ask the family at all, we aren't going to get any sort of an answer, right, wrong, or indifferent. So I think asking the question, who are you seeing, getting that comprehensive list to figure out who they're seeing and trying to figure out. Now I'm going to tell you what, I think sometimes with us at Integrated Services jumping in and, you know, that's what we do as care coordination, being able to say, oh, you go to Summit Pediatrics, we probably know that there's care coordination there. We don't know every place there's care coordination automatically, but trying to help flesh that out. All right, I'm going to stop beating a dead horse on that one. Let's go to the next slide. I just want to throw that as a point of contact. Gabby, please.
Yeah, I have one more question.
Please.
So how many of you are actually working with the care managers or case managers from the health plans? You know, because now you have care coordinators in the clinic, then like the university health plan, they have care managers, and then Select Health has care managers. So how, as a care coordinator in the practice, do you reach out to them and coordinate the care with them, or is this some two different silos existing next to each other?
And that's a terrific question.
So Gabby, this is Heather Carlson. I'm sorry, I have COVID brain right now, so I hope I make sense. But I feel like because of platforms like this that we have networked a lot. I'm a care coordinator. I'm sorry, I should probably preface this. I'm a nurse care coordinator for Eric's team in the Integrated Services Program. And we do network quite often with other programs. For instance, we just met with the Midtown clinics here in the Ogden area and did a lot of networking with their care coordinators. We, you know, the other thing that I just wanted to mention is that, you know, like for instance, I got a referral a couple weeks ago from UDAC, and it had referenced in their referral to go to Utah Parent Center as well as Integrated Services Programs. So when I called the family, I asked those questions about where they were getting services, and it turned out that they were working on guardianship with Utah Parent Center, which was fabulous. So I encouraged mom to do that. And then I put, you know, we talked about timing, we talked about being too overwhelmed and one thing at a time. So we're, you know, in that case, I was able to just say, okay, I'm going to put down in a month that I will call you and we can work on DSPD together. And I think one of the things that we can do is just, you know, that interviewing, asking a lot of questions, figuring out where that family is in this time and space, what their main concerns are, where they're getting help, and where we can fit in. And so for this case, you know, I can fit in, and I'm planning on going out to this mom's home to do DSPD with them. And then I think it's really helpful to the families to provide written information. So like a follow-up email, which I know a lot of us do for integrated services, is we talk on the phone and tell them, don't worry, we're going to send you a summary, an email summary. So you don't need to remember everything I say right now. And, you know, so then you go over, hey, you're going to do Utah Parent Center, and this is where you're working on this. And then here's information on DSPD, and then we're going to work on that. And another thing I think our program does well is that we're working on QI stuff and going back and looking at our charting information and how we're closing that loop with referral sources and where we can improve on making sure that people that refer to us are getting that information back. So we're doing that monthly to make sure we're providing that information and communicating with all of these wonderful programs that we get to work with. And I honestly am not sure if I made sense.
Oh yes, you made sense, Heather, and that was very, very informative. Thank you so much.
Yeah, just lastly, I think when you get these phone calls from these families, if you're a care coordinator, that providing these the interviews, making sure that it's patient-centered, that it's family-centered when you're talking to them. I think that helps guide me in the best way possible for the families by asking all these questions of where they are. So I think if you know, trying to figure out where they are, as long as you keep in your mind that it's family-centered, it really helps provide that direction inherently.
Great.
Thank you, Heather. I appreciate that.
I've had cases in the past where, you know, they call, they need help, and that's, you know, that's our pick up the phone and try to help them. Not knowing, you know, sometimes we jump into stuff and don't ask that question. So this has been a big light bulb for me to say, are you receiving coordination or care for anyone else? And some families may say no, and realistically, they're working with, you know, integrated services and connector services over at primaries and, you know, whoever else maybe. And so it does muck things up quite a bit when, you know, there's so many people working on the same thing, but the family's not letting you know. So I thank you for this, because it's going to be, it was just a light bulb. Yeah. Are you receiving care or coordination or anything from anyone else? And sometimes you end up with a family that kind of, without saying this in a bad way, they'll shop around to get what they want.
You took the words. I was just going to say, Tina, sometimes we get folks that are shopping for the best answer, and I can't blame them sometimes for that.
Yeah, and so, I think that like Corrine and myself, we've connected a couple of times, get it, connector care, connector services rather. I think that we've made that connection a few times of, oh, I'm doing the same thing Tina just did. Let me give her a call. Or we'll find out that, these are, and I'll have to let the family know, you don't want to have so many people doing the same exact thing, because then you're going to have X amount of applications for Medicaid, or you're going to have X amount of, it just, so sometimes we have to, and then sometimes I also think that having a couple different sets of eyes on things has helped in some cases where we're trying to figure out what's really going on and in the best interest of the child. So yeah, I think, as long as we can, if I find out, hey, somebody's working with Eric or with, integrated services, then I can call over there and say, hey, let's not, duplicate what we're doing. What can I do to help? Or something, along those lines, because I think we all have a good things to add, but how many cases does this really make on one family, across our state or our valley or wherever we are? So just a thought. And then the care manager for insurance, I think families should have that care manager and some kind of care coordination in their local area, because the care manager could very well be in a different state, and they're not going to know what necessarily Utah has in place, but they're going to know what that insurance policy or that Medicaid, whatever they're using, what they can provide, what they can appeal, and so those are big things that can assist the family on that insurance side.
Just to throw in a little regarding care managers for insurances, I've dealt with them before with the family where we call together to get a list of providers that they can go with. And over 40 minutes of calling, every single provider was not taking new patients. And this came directly from the insurance company, which I can see how this could be so frustrating for parents if they're calling and nobody is taking new patients. So it's not as easy as just saying, well, we'll refer them to the insurance or we'll refer them here, because a lot of the times they're still running into roadblocks, even from the actual care managers from the insurance company. So it's a little more complex than we think when we're trying to connect these families.
It takes a village. All right, folks, we're running short on time, so I appreciate the discussion. We're going to jam through these next slides really fast. I'm going to let you read through these on your own. But comprehensive, this is where it gets to a 4-point font, but there's all sorts of, this one where it's comprehensive really touches a lot on care coordination, the types of information that are provided, the advocacy, and quite often you are in a role of stepping in for that provider when the provider just doesn't have time. Quite often the care coordinator steps in as the agent for that provider. Let's look at the next slide. Coordinated. This is the one, when I originally put these in, I thought, oh, this is where all the care coordination is going to come in. Now, care coordination touches on every single slide we have up here. This is, coordinating multiple providers, providing recommendations to the family based off of the provider. I know that when Dusty and I were talking, she says quite often she's going in and she's explaining the why we're doing certain things. The provider may not have had time, and this is why we're referring you over to this practice. And, quite often that's what we're doing in care coordination, is saying, this is what the provider wants, and this is why we want to send you over there. So we can kind of figure some of that out. Let's have the next slide. Okay, this is where it jumps to a 20-point font. Compassionate, and I don't think anybody here has a problem with that. You do what you do because you are kind, compassionate, and caring, and understanding and trying to empathize with the family. And I know some of these families can be super frustrating. but I think you all do a bang up job with that. Let's have the next slide. And culturally effective. I know that we are going through a lot of training in Department of Health to talk about how we can be culturally, linguistically sensitive to the families that we serve and understand the families that we work with. And I think that's happening nationwide. And so I hope your practices are looking at that as well. Let's have the next slide. And Dusty, I'm sorry, I'm just slamming through all of these. So I hope I'm not writing shod on you here.
No, but can I grab this one?
Please.
So, so we kind of wanted to have a discussion around this, but we are short on time. I would be super curious if any of your patients receive automatic care coordination, and how you qualify that, right? So how are clinics qualifying that? I think this would be an interesting discussion even for a future topic, because the things that prompted this were, you know, for autism, such an easy one for me to pick on, but for my kiddos that we suspect are going to receive a diagnosis of autism, we just kind of automatically have our things we do. We start conversations with the family, they're concerned, and so we start with the coordination early on them, because there's a concern, we have a direction, we kind of can anticipate what to expect. And I'm curious if there are other potential diagnoses or concerns, maybe not even a full diagnosis, right, or an official diagnosis, that automatically get put into care coordination. So again, that might be an interesting topic for a future discussion.
Let's just pop a couple of questions out. How do people determine? Just a few real quick answers on this one. In your practices, how do you determine who gets care coordination?
Maybe Yvette could answer that question, because as a care coordinator at UPC. So how does it work at UPC, Yvette?
So usually the provider will see them, and usually when the patient is identified as a socially and medically challenged family, then we definitely will pop in, as well as when they get those questionnaires at the beginning of the visit, and family lets us know they're struggling at a certain point, then that's when the care coordinator jumps in. We don't go off of a list and say this patient has a certain diagnosis, but more so where they are in their overall state.
Right.
Okay, great. Okay.
Oh, Angie, our providers identify need and make referrals to our various teams. Thanks, Angie, for the info.
Yeah, I appreciate that. Very good. All right, let's go ahead. I think we can skip over probably, we already kind of talked about this just a little bit. Let's go to the next one, which we talked this one already. We jumped the gun on that one. And, you know, who takes the lead? That's an interesting question that we can kind of defer to another time. Let's go to the next slide. Okay, so let's throw this one out really quickly, just a few quick responses on this one. What do you find to be the challenges in providing effective care coordination? What are the biggest barriers or roadblocks for you in your practice?
Wow, Eric, I don't know if this qualifies for a quick answer, but I will put it to the group. So, okay,
Natalie says overwhelmed families.
Yeah.
One or two word answers, folks.
Language barriers.
Okay, I agree, Sylvia. What else?
Financial barriers.
Limited resources. Very good. Thanks, Natalie.
What about just nothing in the area where you live to try to refer families to you? Sometimes, you know, that's a big problem, isn't it? You know, trying to scrounge up and say, wow, where am I going to send this family for those needs? So lots of big challenges there, but folks are super innovative. Let's get that next slide, because this is where I kind of want to end things today, and just say, you aren't alone. And that's why we have these meetings every month, to be a forum to discuss what we do, to talk about the art of care coordination, to make things better for the families that we work with. Rely on your internal partners, people you can rely on. If you're in a big practice like a Wasatch Pediatrics, are there people that can help you in other practices with the care coordination side of things? Reach out internally first. Secondly, if you do not use the UCCCN listserv to ask questions from the group, hi, I've got a tough case. This is the issue. How can you help me? We get amazing responses back from this group. So if you have not used that feature, reach out with your tough cases. There's a wealth of knowledge here from these amazing people on this call. Also, Utah Parent Center, in case you haven't gathered already, Tina Purcell's and her gang over there, they are some of the smartest people I know, and they have the lived experience. Reach out to those folks as well. They know so much. We are always willing to help at Integrated Services, and we are willing to tag team with you. We realize some practices are limited with the time and ability to help, and we are always willing to hop on and help you with there as well. And as we already mentioned, those insurance kind of case managers, care people, they can always help you as well. So reach out for help as needed.
Well, thanks, Eric. Thanks, Dusty. So we have 1 minute left in this meeting, and I told Eric I would cut him off right at 10 o'clock, and that's what I did. Folks, thanks so much for joining us. Our next meeting is July 20th, and the topic will be mental health. And we have some great speakers. Heather Shotwell is coming on, and I believe Lisa Charles is coming on. So I think I'm really looking forward to that meeting. But to all of you, I wish you a wonderful Wednesday, and then see you next month. All right.
Everybody, we appreciate you being on today.
Take care, everyone.
Thank you.
Bye.
Bye.